Hello, my name is Ben Neville. I am the Integration and Priority Applications Manager at Southwestern Sydney PHN. Welcome everyone to Preventing Obese Adults, How to Manage Overweight and Obesity in Children. I'd like to begin by acknowledging the traditional custodians of the land on which we meet today. I'd like to pay my respects to the elders past, present and future, and extend that respect to those in the meeting who identify as Aboriginal and Torres Strait Islander people. Just a couple of housekeeping issues before we begin. First off, this session is being recorded, so just letting everyone know that. It doesn't keep a record of the chat though. Everyone will be muted throughout the session, so therefore if you have any questions or comments, if you could please put them into the chat, that would be greatly appreciated. As you can see above, we have 4 presenters tonight. Each of them will be presenting a different section, and what we will do is we'll pause after each presenter, and there'll be opportunities to do a bit of a Q&A or a quick questions based on that section of the question, that presentation, and then at the end there'll also be a bit of a Q&A section as well. That's there. So please put your questions into the chat. We will be monitoring that. At the end of this, you will be provided with a link to an online evaluation, as your feedback does assist us in continually improving our programs. That link will be posted into the chat. All participants are required to stay for the duration of the meeting in order to receive your certificate and points, and certificates will be issued within 1 week. I have confirmed with the presenters that a copy of the slides as well as some resource packs are able to be made electronically, and they will be sent out with your certificates as well. But in addition to that, there will be some discussions about some printed packs as well, and some of the ways potentially about how to access those to provide to patients within your practices as well. So the final thing I've got here on my list is a GP feedback form can be made available on request if anyone has a grievance about the meeting, but I'm pretty confident everyone's going to find it really useful and not have any needs for one of those forms. But if you do, let us know and we can give one to you. So introducing the speakers, Faye Southcombe is a dietitian and team leader for the Growing Healthy Kids service. Dr. Lily Pachidi is passionate and has extensive experience in the management of obesity. She works in a holistic and multidisciplinary approach, delivering professional advice on weight loss therapies available in Australia, including bariatric surgery. Slavica Kristic is a clinical nurse specialist for the Growing Healthy Kids Weight Management Service. Slavica embedded routine practice for height and weight screening across all clinical services within Southwest Sydney Local Health District. And Dr. Shabina is a staff specialist for Growing Healthy Kids Weight Management Service. So if I can hand over now, I think Slavica, are you presenting first? Just you're on mute at the moment. I'll hand over.
Sorry, yeah. Yep, Dr. Liliana will start, yeah.
Oh, sorry, Dr. Lily will start. And I'm just going to mute myself and turn off my camera, but I am hovering in the background monitoring the chat.
Awesome. Yeah, so, well, good night, good afternoon, and very, very happy to be here. And I hope everyone has a good time and can have a bit of fun and learn a bit as well. So today we're talking about prevention in overweight problems in kids and trying to prevent in adulthood. So some of the learning outcomes will be interpreted the prevalence, health risk and implications associated with overweight and obesity in children. Develop a system that changes that in your practice that actually can improve safety of patients with these conditions. Describing as well as best practice recommendations and management, very relevant to primary care and general practice. And trying to have a better understanding of routine screening and management that we can actually do day by day with our kids. So you can go to next. So that's Faye.
All right, good evening everyone. So I'm going to speak next. I'm going to start with thinking about some of the myths or the common themes that we sometimes encounter in our practice with a bit of true and false section. So for you to contemplate in your own mind, true or false, to reduce obesity, you need to eat less and move more. So this one's both true and false. So it is true, in fact, that most obesity management or treatment strategies will result in a reduction in energy intake and trying to encourage people to increase their energy output through an increase in physical activity. It's really important to note that it's far more complex than this though. And so obesity management often includes things which are outside of food and exercise. And these might include looking at sleep patterns, looking at psychological stress, things like chronic pain, endocrine dysfunction, and medication management. So next, true or false? People with obesity are lazy. So I'm assuming you've all guessed false on this one, but it's a common myth. And there's some really good data to indicate that people who are affected by overweight and obesity have the same levels of physical activity as many people within a healthy weight range. So true or false? If your close relatives have obesity, so will you. So this is false. Although genetics does play a role in the causes or the etiology of obesity, your environment and the familial environment play a far greater role. So the effects of family obesity, or your parents and the people around you being affected by overweight and obesity, will have an impact on the children and young people, but the impact through the environment that surrounds them is far greater than their genetics. So true or false? Obesity in childhood has immediate and serious health impacts. I think one of the myths, this is in fact true, and one of the myths that we commonly come across is that the belief system that children might grow out of it and there's no residual impacts. But we now know for some really good evidence that around 7% of children and young people with obesity and about 33% with severe obesity are affected by 3 or more serious health obesity-related comorbidities. So these are not future effects, but these are the immediate effects. So we commonly see children in our clinical service who are affected by sleep apnea, some digestive complaints or diseases, non-alcoholic fatty liver disease, as well as dyslipidemia and some of the impacts of the obesity on insulin. So true or false? Puppy fat is normal in childhood and kids will grow out of it. So this is also false. And the transference of obesity in childhood into adulthood is one of the greatest risk factors associated with obesity in childhood. So in fact, 88% of children and young people who are affected by severe obesity and 80% of children affected by obesity will go on to have obesity or severe obesity as an adult. So that there's a very high level of transference. For overweight, it's around 64%. So I can tell it. So go ahead, Lily.
Yeah, I can tell the child's weight status by just looking at them. What do you think? Yeah, a bit tricky, that one. And we can go through the pictures and have a look. So yeah, what do you think, guys? So that's just example. So who do you think who actually is in a health weight, or either below the weight or above weight or well above weight? What do you think? Anyone would like to put in the maybe the message or just have a think? Any ideas? So basically, so if you can go through, so which would be like little chubby, which I don't like really these, but like in the left side, we can see that's way above, and actually on the middle, which would probably be considered below the weight, is actually normal weight, which we call it healthy weight. And on the right is actually a bit above the weight. So definitely doesn't mean that they're not healthy or not. That just mean that at the moment, we have to do some action just to prevent implications in the adulthood.
All right, thanks, Lillian. So parents want to talk about their child's weight. True or false? So this is generally true. It's a common myth that we come across with our healthcare practitioners, is that they perceive parents would not want to talk about the issue, that it's a sensitive topic. But research generally supports that parents feel comfortable talking about the weight of their child when it's discussed in a non-judgmental manner. And in fact, if parents and if the healthcare worker is not talking about the weight with the child, with the parent, then the parent is often assuming that there is in fact no issue. So true or false? Obesity treatment doesn't work. This is false. So a lot of it, there's an enormous amount of evidence around the efficacy of obesity management for both children and adults, and all obesity treatments are generally effective, and they'll be less effective for some people and more effective for others. But when we look at the evidence as a whole, obesity treatment is definitely effective. So treating obesity in childhood can cause an eating disorder. True or false? So this is false. Dieting is certainly one of those self-reported practices which is often used to control weight, but well-structured multidisciplinary weight management in fact reduces the risk of an eating disorder. So most people will think about anorexia or bulimia when they think about an eating disorder, but in fact, binge eating disorder is far more common than both anorexia and bulimia combined. We certainly see it in a number of the children and young people referred to our service, but it's not a result of well-structured intervention. And well-structured intervention is in fact protective. All right, so that's the end of the true and false section. So this next section is going to cover a few things for us today. So we're going to think about how common is obesity in children and young people. What are the health consequences of obesity in childhood? What's causing it? And have a think about some of the treatment, look at our evidence, the principles, and some practice recommendations, and then have a look at some case studies as well. So how much of a problem is obesity in children and young people? What are your thoughts? What proportion of the population is affected by overweight and obesity for our school-aged children? So 22 to 24%, and 7% of that are affected by obesity. For school-aged adolescents, it's a little bit higher at 27 to 28%, and 5.5% affected by obesity. For children aged 4 to 5 years old, around 20% of those are affected by obesity. And what about for 4 to 5-year-olds who identify as Aboriginal? We increase it to 28%. And then for school-aged children who are of a Middle Eastern background, it increases again to 42%. All right, so obesity prevalence in southwestern Sydney local health district versus our New South Wales population levels stats. So this is data taken from the 2017 to 2018 for children aged 5 to 14 years of age. So most children for New South Wales sit within the healthy weight range, but around 24% of children are affected by overweight and obesity. So 17% of those affected by overweight and 7.7% affected by obesity. So we can compare this to the chart next to it, which looks at the similar age range, 5 to 16 years of age, for children and young people in southwestern Sydney local health district. So prevalence increases in our district. So around 1 in 3 children is affected by overweight and obesity. And here overweight increases to around 18% and obesity is dramatically increased at 19%. So this next chart looks at obesity severity over time. So you can see some of our population level data here and looking at the proportion who are overweight, who are affected by obesity, and that top end proportion, which we commonly refer to as severe obesity now. We used to say morbid obesity. So of those school-aged children and adolescents with overweight with obesity, more are proportionately affected by severe obesity, and this is increasing over time. So when we look at central obesity as an indicator of metabolic health, we look at a weight to height ratio being greater than 0.5. And we can see from our population level data that this is also increasing over time. So fat distribution is changing and that prevalence of central obesity is increasing. All right, so New South Wales data, looking at the social disparity in the prevalence of overweight and obesity also gives us an insight into what might be some of the impacts in southwestern Sydney LHD. So on the chart, you can see that those in the lowest quintile for socioeconomic status have an increasing prevalence of obesity over time, and that this increase is getting greater over time. All right, so why is obesity in childhood a problem? So you've probably seen this image before, but it just talks to the fact that there is immediate consequences for obesity in childhood, and these involve all of the bodily systems. So we can expect to see children and young people affected by obesity with some of these complications in all of our practices. So obesity affects our gastrointestinal system. Fatty liver disease and non-alcoholic fatty liver disease is something we commonly see in our clinical practice. We also see a very high level of nutrition-related deficiencies, particularly iron deficiency, vitamin D, and vitamin B12. Obesity has impacts for our endocrine system with insulin resistance and polycystic ovary syndrome, commonly seen in our children and young people affected. Sleep apnea and other pulmonary-related conditions are part of the obesity effects, as is cardiovascular related conditions, some renal issues, and then there's also the orthopedic concerns. All right, so looking at obesity in more than just a physical health issue is this lovely slide from the World Health Organization. So the impacts of obesity are immediate, but they affect more than just our bodily health. So children affected by obesity definitely have that poorer health outcomes, both in the short and the medium and the long term. They also are affected by lower levels of self-esteem. They have a higher likelihood of being bullied at school. They also have poorer school attendance, and they have poorer levels of school achievement. So this moves on to an adulthood, which has a higher likelihood of chronic disease and a higher likelihood of obesity carried through to adulthood. We also know children and young people affected by obesity have poorer employment prospects as an adult and often end up in lower paid positions. All right, so weight-related comorbidities are increasingly observed in children and young people, and it's something that we've gotten very comfortable with looking at in our clinical care. So for us, around 42% of the children and young people that we see have at least one weight-related comorbidity, such as prediabetes or hypertension or non-alcoholic fatty liver disease. So this is a lovely review which looked at the increased prevalence of some of these complications of obesity in children who are affected by the different weight scales. So you can see there's some columns here for children who are healthy weight, overweight, and then obesity. So we've highlighted some of the columns which identify some of those issues which have a much higher prevalence ratio. So for example, insulin resistance is 10.8 times more likely in children and young people affected by obesity. Likewise, low self-esteem is far greater, as is high blood pressure. Children and young people have a much higher incidence of hyperglyceridemia when they're affected by obesity. They also are more likely to have the metabolic syndrome. And at the bottom, we've highlighted there the higher prevalence of non-alcoholic fatty liver disease. All right. So obesity in childhood increases the risk of obesity in adulthood. And we talked briefly about this in the question and answers, but I think it's really important to reflect on. So severe obesity is quite common and increasing in the children and young people affected by obesity. We certainly see a higher level of referral for children and young people affected by severe obesity. And for us clinically, it represents around about half of the children and young people who have a referral to our service. So 88% of these children, 80% of children affected by obesity, and 64% of children affected by overweight will go on to become to carry obesity, severe obesity, and overweight into adulthood. So it's definitely a problem, and there are real health consequences. But what's causing obesity? So there's multiple models for causation for obesity, and a lot of them tie into the socio-ecological model, which is what we've got pictured here. This was presented by the WHO, and it just draws on what we know and observe clinically is the complexity of issues which are layered around a child, which have impacts on how they grow and develop. So in this model, we look at the child in the centre, affected by the family unit, their culture, their immediate economics within the family, and that is nestled within the residential community, which might have effects on things like safety or the perception of safety at parks, the availability of parks, the local transport system, or in some places, you might find that fast food is far more available than fresh food. That's within a system of their region and their regional economics. So that affects food availability, the access to exercise, the economics of the family as well. And that's nestled within our national system and then within our global system as well. So what's within the individual's control is often quite limited when you look at what has an impact on the likelihood of developing obesity. So can obesity be treated? So there is a plethora of information and systematic reviews around obesity treatment in paediatrics. And all of these have recently been combined in an umbrella review. So within the umbrella review, we've got on the next slide a picture of their forest plot. So looking at behavioural interventions for adolescents. And you can see on the forest plot that most interventions are definitely effective. And this looked at a mean change in BMI of 1.18, which is a significant change in BMI. So on the chart that we're on now, we've again got a similar forest plot for treatment versus no treatment versus intervention. And all of these interventions combined again had a treatment effect of minus 0.53 BMI units.
I think we can pause for any questions. I can't see the chat, but hopefully Ben is there that is able to read any questions for us.
At the moment, there is no questions,
Okay.
but I encourage all of the GPs attending tonight, if you do have questions, please put them into the chat and we'll get those answered for you.
Excellent. So thank you. I might move to the next part. So we know now that obesity is a problem and it can be treated. So what is our role and what can we do about it? So the evidence supports screening for obesity of all healthcare patients, combined with referrals to appropriate interventions services as well. Now, how we advise to do this is by using what we call a 4A's approach. So 4A stands for assessing, advising, assisting, and arranging. And I will go through them in stages. The health is also developed a website called Pro Healthy Kids website. And all the resources that we're using today will be available on this website as well. So the first part for us to do is to assess. And now when we say assess, what do we actually mean with that? So we need to do the height and weight measurements or length measurements for all children presenting to our services. But we want to make sure that we use the right equipment and we do it accurately. So just for you to consider, what type of equipment do you have? Has it been calibrated? Is this something that's appropriate for a child? We would like the infant scales to be accurate to 10 grams. And the weight capacity of at least 20 kilograms. also to have a different type of scales available. And we also like stadiometers to be as accurate as millimeters as well. Now, when you're measuring a child, we want to do it appropriately. So making sure that there is no shoes on or heavy jackets, asking the child to stand nice and tall, having legs together. So adding 2 centimeters to probably an adult height might not make much a difference of a BMI, but adding 2 centimeters to a child's height would actually dramatically change his BMI. There is a growth assessment in children and weight status assessment guideline that actually tells us how to do this, what equipments we should be using. So you feel free to refer to that as well. But assessing the child will be pretty much the same formula. We want to calculate the BMI for anyone who is 2 years and above, using the same formula as it's used for adults, except by calculating a BMI for an adult, you might say it's 22, and we know that's a numerical cutoff, that it's a normal weight. However, for kids, we have to plot it onto the BMI for age percentile chart in order to interpret those findings. So the charts are available and they are color-coded. As you can see, this is only recent change the Ministry of Health did for us, nicely coded in a traffic light. So anything in the gray zone, which means they're below 5th percentile, and what we call is below a healthy weight, your underweight kids. Anything in a green zone, 5th to 85th percentile is a healthy weight. 85th to 95th, what used to be overweight, we're now calling it above a healthy weight, and anything above 95th percentile goes in a red zone. Obviously the obesity. Now, this is really nicely perfect chart to use to present to parents. Now, when you plot the dot in a red zone, or even sometimes plotting the arrow above because the BMI is above high, it's really, really visual tool, really good tool to use to present this to the parents. Now, be mindful there's boys and a girls chart, so make sure you're using the right one as well. Now, you might notice that we've done the assessment, we've done the height and weight measurement. Our next part is to advise the family. So there has been a lot of work about what language do we use and how do we present these informations to the family. So recommended language now is, instead of using word obese, we were saying well above a healthy weight. Instead of using the word overweight, above a healthy weight range, or underweight, below a healthy weight. So you can probably notice the focus is on health. Now, the next step is, once we advise the family where the child sits on their category, is to give them some tips. Okay, so to give them some advice that they can do to follow on. So these resources are again available on Pro Healthy Kids website. But the advice we want to give them is what we call our 8 healthy habits. So we want to focus on things that family can do at home. So number 1 is drinking water instead of soft drinks, juices, or cordials. So encouraging family to mainly drink water as a main drink. Aiming to eat, now the guideline says at least 5 serves of vegetables and 2 serves of fruit, but we know that there might be a hard target to achieve with the vegetables. My usual advice is to increase the vegetable consumption. The next part is to have a healthy breakfast. So things like Weet-Bix, porridge, eggs, whole grain toast, yogurts might be a good option. Portion sizes, so knowing your portion serving size. This one is a little bit tricky for us to know because all kids come in different age and sizes. So just advising parents to be mindful of how much the child takes, and you really shouldn't be eating as much as an adult. There is a guideline there's a brochure that we can provide you with as well, that gives you a little bit of a guideline of how much a child of each age should be having in their portions. The other part is choosing healthier snacks and fewer treats food. So things like, instead of chips, having popcorns, instead of ice cream, having yogurt, and encouraging more carrot sticks, cucumbers in their lunch boxes as well. Now, number 6 is limiting screen time. So this is usually a big one, and a lot of our kids could have advantage of this. And we actually advise for kids 2 to 5 to have 1 hour max a day, and above 5 to have 2 hours a day. And having enough exercise in a day. So we want the kids to be at least active for at least 60 minutes every day. And I always announce this to the parents, at least. So it's a minimum requirement that they really should be having as well. Now, getting enough sleep as well, and the actual tool will tell you how much they should be sleeping in each age as well. So these are a few things that we kind of discuss with the family. And at the start, we usually like them to pick 1 or 2 strategies at a time, because some family might kind of say, oh, my child doesn't do any of this, and might try to do all of this and fail. So what we usually encourage is focus on 1 or 2 things at a time. And once the child achieves those things, then you move towards the next one as well. Now, all of these resources are available in different languages as well. So if you visit prohealthykidsnewsouthwales.gov.au, you'll be able to download those resources in a different language as well. Now, we've told the family where the child sits in their category, giving them some tips. So next step will be to refer them to the services appropriate to their category. So we have developed for our district, we have developed what we call a referral pathway. And this is something you can use to guide you. Where should I be setting each child, depending on their age and category of the obesity as well. So someone who is sitting up below the healthy weight, we usually refer them back to you guys. There is also early childhood services. Someone in a healthy weight, that probably just needs a reminder that the child is growing healthy. And again, going through the 8 healthy habits is a good thing, because just because child is in a healthy weight does not necessarily mean they're following a healthy lifestyle. And then someone who is above a healthy weight, our options will be Go for Fun and also referral to Get Healthy. I'll go through them in a minute. And then anyone who sits in that red zone also will be candidate for either Go for Fun, Get Healthy, or to the Growing Healthy Kids service as well. So I'll go through them. I'm sure everyone has heard about Go for Fun. Go for Fun is a government-funded program that runs for about 10 weeks. So the child, it usually runs with the school terms. It doesn't have anything to do with school, but they're just using school terms as a term for enrollments. Now, Go for Fun is for anyone between age of 7 to 13 years who sits in that yellow or a red zone on that BMI chart. Now, the referral form is available online. There's also brochures and things you can order from them, and they'll deliver them to you. But this is what pretty much the forms look like. They have an option of online Go for Fun program. They also have a face-to-face program where the child comes in 2 hours once a week, has a physical activity, and the parents get education on healthy lifestyle as well. They also have an Aboriginal Go for Fun program. If they identify as an Aboriginal, they'll be offered that program as well. Now, the other option is Get Healthy. Now, this is for our little older candidates. So anyone who is 16 plus is qualified, sits in the yellow or red zone, can actually go to Get Healthy program. They also can self-refer for both of these programs, but we know that if they are referred by health professionals, they are 2 times more likely to attend as well. Again, the form is available on Pro Healthy Kids website for a referral as well. And they also have a brochures available for them. Now, I usually think of this as something for adults, because you can just imagine if the parents enrolls in a healthy lifestyle program, the child will benefit as well. Now, the last option for our district for something to assist with the weight is our weight management service, Growing Healthy Kids service. This is a kind of a newly open service. We've probably been existing for about 2 years. It is a multidisciplinary weight management service. On board, we have a clinical psychologist, dietitian, exercise physiologist, nurse, pediatrician. On board, we should have soon pediatric endocrinologist and a social work as well. So to refer to us, the child needs to be between age 2 to 17, but must be in that red zone on that BMI chart, or it can be lower if you identify any weight-related comorbidities. Another criteria is that they must be residential, they must have a residential address within our district, and the service is located across the district. So we have clinics at Fairfield, Liverpool, Rosemeadow, Bankstown, Ingleburn, and Burrell as well. Okay, any questions so far? Is Ben still here? I can see 2 charts.
I am.
Yeah.
There are 2 questions, both from Dr. Chiku. The first one is a question that comes after my own heart as a person who is 6'6", and that is, many obese kids are also tall, not uncommon to Big Johnny. does the BMI not be less accurate?
Okay, we get this a lot of times. A lot of family challenges us with this. My advice usually to the family, and a lot of times my advice usually is that BMI chart is a tool, but it is the most validated tool in the world. I don't usually, sometimes if you can't convert them that it is the child is above a healthy weight, I sometimes put the BMI chart away and just focus on, is your child living a healthy lifestyle? Is he having, you know, right amounts of vegetables and fruits? I don't know, Faye, do you or anyone else wants to?
Yeah, I was just going to say, I guess if they are taller, then they will naturally have a higher body weight and proportionately still be within a healthy BMI, because your BMI is a proportionate measure of how much weight you have to your height. I always sort of mention with children and young people, having extra body weight usually often results in an early height attainment. And so children will have accelerated height attainment, and it usually doesn't correct till around that 12 years of age. So they may appear much taller than their peers at a younger age as well.
And the other question that we have here is, many kids have a lot of carbs and have carb craving. Do you advise on carbs intake at all?
Yes, I guess this is one for me as well. We absolutely do have some specialist sort of treatment which really does concentrate on the macronutrients, and carbohydrates being one of those. But I guess that is a specialist treatment and something we would do if a child was presenting with some non-alcoholic fatty liver disease, or if they're pre-diabetic. And in those circumstances, having a highly carbohydrate restricted diet is actually, from a treatment perspective, is very beneficial. But for the general population, carbohydrates represent a really important part of our diet and one of those three sort of macronutrients. For general guidance, carbohydrates should represent about 50 to 60% of the total energy intake for most children. And so carbohydrates really are many of our food groups. So all of our grains have a carbohydrate content. All of our dairy is very high in carbohydrate. Fruit is a carbohydrate, and many vegetables as well. So carbohydrates are really important for energy and growth. They come from most of our food groups. If I'm thinking more in general treatment principles, I'd be more interested in looking at the source of the carbohydrate. So often when we say carbs, we're referring to refined carbohydrates. So even things like white bread or cruscets or rice cakes are very heavily refined products. And so then you get a really rapid increase in your body sugar uptake, and that's a higher likelihood of that being stored then as body fat. And then you get the cycling in your satiety and hunger drive as well.
Okay, no more questions?
Oh, that's all the questions for
Okay,
now.
not a problem. I'll hand over to Dr. Lilian.
So I'd like to talk about a bit more about the raising the issue of obesity. So starting talking how we actually address with our patients if they are overweight or if they suffer from weight problems. Talking about in general, so in general practice, honestly, we do have weight bias, and it's a bit sad because research shows that the patients do feel that suffer from obesity, they do feel stigmatized when they actually go to the health service. And why was that? So technically, many researches was actually made with medical students, dietitians, GPs, and nurses and exercise physiologists that technically, unfortunately, they do tend to have a negative attitude and even a negative feeling that people with problems with weight, they are lazy or they don't want to take care of themselves, or basically they just have self-put control, or actually they just don't bother, which is actually not very true. So what we can actually do to try to avoid this negative attitude and be more welcoming and actually more approachable for these patients. So I think understanding initially the complexity of obesity, which technically it's a several combinations of factors that was said before by Faye. Genetics is a big basis, but also environmental, psychological. And I would say also being a bit more invited and more open approach than just saying, look, just eat less and exercise more. I think we can definitely help our patients to feel less embarrassed and helping them to actually ask for help. So another thing we could also do, at least in our center, while we do be more welcoming, be sure that you have the right cuff for blood pressure, larger chairs, and even larger tables to examine your patients, to make them feel part of your health system. We are there to help. So in regards of kids, it's very interesting because we have the CAPE project that they assess 300 parents, and 83% of those parents, they're actually not aware of the child weight status. And to be very honest, if you look at the back of that pictures, when we look at, I actually, my first time when I looked at the pictures of that 3 kids, I got wrong. So technically talking, even us, we need to think in what is actually a health growth and how we actually properly help our patients to identify kids' problem in just reinforcing that's not only a matter of looking, but also plotting on the chart and showing the parents what we can do. So non-judgmental approach, normalization of the clinical measures, that's a very important thing as well. Otherwise, they think, oh, it's just because my teenager or my kid is just a bit overweight, that's why you're waiting. So not making them feel this way, making them comfortable. And to be honest, if you be open and non-judgmental, they are comfortable to talk. They will say, oh my God, I'm not sure, I wasn't aware, or actually I was just brushing it off, but thank you for approaching, and they will ask for help. I feel as well, making sure the language, so trying to not use fat or obese or severe obesity, especially like kids and teens, they do get that, and it's actually not nice, and parents get a bit frustrated and actually a bit angry if you do this way. And I feel honestly, lifestyle changes, they are possible in the general practice. I really admire, look, if we could have several services as we have in Barrow, Rosemido, and everywhere, it would be great. But we can do a big job with our patients, yes. So I would say, rather than just looking on number of like the number on the scales, if the kids you're doing a follow-up, they didn't lose much weight, but they are actually engaged or they're actually changing a bit of lifestyle, that's the main thing, because then we will actually have a big result in the weight, and not only on the weight, we'll get a big result on the kids' health. So yeah, let's just keep going. And yeah, that's what I say, small change makes all the difference. So how could we actually start this conversation? So how actually confident we are to talk about, hey, actually have a pay attention to your kids' weight or what we're doing. So I myself say, honestly, I tend to brush it off a bit, the subject or maybe the approach. So not pinpointing things that they're doing wrong, which I think this is really, yeah, it doesn't sound good. So I generally tend to focusing on health. So check the kids, make sure, look, I do all the time, I do on vaccinations, and when we need to give antibiotics or whatever, just try to really maximize the weight measurement in your kids. And with that, I'm sorry, my kids here. And with that, I would say, be more like a normalization of your approach and talking with them about what actually is the status of your kids and above weight, if they are well above, if they are very well above, what we can do to implement change. And look, they are very welcomed, to be very honest. So understanding the issue, plotting on the chart, that's a very important thing. I always plot on the chart, show them, there is the pictures, and it's amazing they do the traffic lights. So you actually put, look, that's the red. So they're way above the health wage. And mostly of the parents, they actually didn't know that. So I would say, pointing that, showing strategies, and also talking about complications in not only immediate, but in the future. So problems with obesity, conditions like insulin resistance, polycystic ovary syndrome, mental health conditions, possibility to be bulged at school. So we have lots of things that if we don't do now, we will actually not prevent all these problems. We can have a big impact in quality of life. So changing lifestyle, it's a big hole. And look, we need to understand, it needs to be baby steps. We can't do that in one only consultation. It needs follow-up, needs assistance. And if you can do together with your dietitian, your exercise physiologist, it would be great. So it's possible. We can do in general practice, definitely encouraging your family and the parents to change lifestyle slowly, and arranging proper follow-up would be fantastic. When they want, which generally we have proper referrals, we can organize locally, depending on the situation, but we can do a bit of job as well in the general press, which is great. Just in the end, we also, sometimes it does happen. Sometimes we talk the subject, look, unfortunately, I don't want to talk about that now. I'm busy, I just came for a script, or I just came to have a referral for the pediatrician. So it happens, but we need to try. That's our job here. We are in primary care and we try to prevent the problem with the weight. Population is getting heavier and heavier, and we're having so many burden on the health system. So that's our job. I keep trying, and I really hope that after today, we all keep trying and we implement change in our approach to these patients. Thank you. So I'll go now to Dr. Shabina, but if someone has any questions, happy to answer. Yeah, all good.
So there is another question. So are there studies that show parents who eat well and exercise regular are good role models for their children?
Sorry, so exercise, sorry, Ben.
Yep. So parents who eat well and exercise regularly, are they good role models for their kids? Is there studies that show that?
Oh yeah, definitely. So look, we have families that they have a very healthy lifestyle, but unfortunately sometimes they're actually busy to like give this actually learning for the kids. They're just working full time. So what I see sometimes, they do have good lifestyle, but towards the kids sometimes they're just busy, and we tend to look honestly leave the iPad a bit longer and not exercising together with the kids. Lifestyle is really getting hard. So I would say definitely parents having a healthy lifestyle will be a role model for the kids in prevention. As for instance, I had parents coming, both of them couple post-sleeve gastrectomy, because actually they were struggling with weight problems for long, and they brought the kids to me to start prevention, which was great. Anything else?
If I can add to that too, it works in reverse. So there's really good evidence that when you take a family-based approach to therapy, the adults tend to lose more weight than their children, even without trying, just by implementing whole family strategies.
I was going to say the same thing. Yeah, definitely. You see parents really taking on the ideas that we give the children, and they lose more weight. And then again, that's more motivating for the entire family. Absolutely.
So there is another question from Dr. Simi. What blood tests would you consider for baseline investigation?
Excellent. That goes perfectly into our next.
All yours.
Okay. In that case, we're going to put that question on hold because it's going to be answered soon.
Yeah, exactly. So I get to see all the children who are well above a healthy weight, and to look for the metabolic syndrome. I also get to see children with comorbidities and above the healthy weight. So what we do is we look for a routine bloods, and we look for metabolic syndrome. We also look for micronutrient deficiency. And then we look for other things or other possible causes for the increase in weight, whether it is CGH array, looking for things like Prader-Willi, or to look for metabolic syndrome with insulin resistance. And sometimes you also find some children with PCOS. And definitely the GPs are the ones who know more about this, because I was listening to the good GP to learn more about PCOS, because you guys see this so much more often than us. So we get to do this in some adolescent girls who come in well above the healthy weight. But mostly what we do is the lipids, the fasting insulin, the glucose, the HbA1c. The CRP we do along with the routine bloods, but often it doesn't have much of a diagnostic value. We just tend to do it along with the routine bloods to see whether there is an ongoing inflammatory process going on. We often find children with vitamin D deficiency and iron deficiency because the younger ones are just not getting those micronutrients as much as they should be getting it. And talking about imaging, so we do liver ultrasound. Often when you have found that they have abnormal liver function tests, especially ALT, we do a liver ultrasound to see for that non-alcoholic fatty liver. And sometimes, if they have got hip pain and those sort of things, we do the hip x-rays and refer them to orthopedics. Yes, next, please. Yep. The metabolic syndrome, as I was talking about. So what it is, I think you guys, again, know more than us in pediatrics, but basically it is the sudden increase in sugar, the glucose dysregulation, which increases the insulin resistance, and then type 2, and then leads to type 2 diabetes. And again, elevated LDL, the triglycerides, and the low HDL. And a lot of our children do have prehypertension and stage 1 hypertension as well. We routinely do, whenever we see the children, we do the height, weight, and also the waist circumference, just because we know that when the waist to height ratio is more than 0.5, it does increase the cardiometabolic risk. And yeah, so again, on bloods, we see increasing levels of fasting insulin. We do get 2 units, which often confuses us, but it is more than 10 in the milliunits per liter. And then the picomole per liter is 115. And then clinically, we can see the acanthosis nigrans, which we unfortunately see quite often in our children, and some symptoms of hyperandrogenism with PCOS, fat deposition, central fat deposition, and they sometimes tell us about muscle cramps as well. And we know that these blood results often are correlate us with visceral fat deposition, that's mainly central obesity, and also you can see the similar type of presentation with prolonged steroid use and in children who are on growth hormone therapy. So what do we do for these children? Luckily, most of this work is done by the amazing allied health staff and the nurses that I work with, but we know that we really need to be in a calorie deficit. So that is what we are trying to work towards. And so we reduce the calorie intake and we try to improve the weight loss. So if we improve our weight loss by BMI by about 8%, you do see very improved insulin sensitivity. But when you do improve your BMI, you do see the insulin beautifully reducing, as you will see in our case study that comes up next. We advise to increase physical activity. As Ravitsa has already said, we want them to have at least 1 hour of activity per day. And in children who have insulin resistance, we start them on metformin, and the target dose is 2 grams per day. And we slowly build it up so that the main side effects, mainly which are abdominal pain, some bloating and diarrhea, is not as significant and slowly wears off within about 2 to 3 weeks. And it also improves the satiety and reduces the energy intake, which increases weight loss. And yeah, like I said, we start low dose and go slow. So again, we try to have an energy deficit. So our excellent dietitians work with the parents to give them a really good meal plan towards this. But the idea is that they have a low energy diet, which is about 1,000 to 1,200 kilocalories per day. We try to go with a protein sparing, modified fast, and sometimes, and then you have traffic light diets. Like these are good foods. These are foods that you should be trying to avoid. And with exercise, we say we need to improve your cardiometabolic profile. We need to get you to have more of endurance. And we start slow again, and we don't want to push them out of the interest of doing exercise. We want the family to be interested, because often if you are pushing them too fast and the family is like, oh, no, he can't do it, and they completely stop. So we start slow and then push the family. So we just start with simple things like fundamental moving skills, light activity, then moderate to vigorous activity, high intensity training, and strength training. And with this process, our families do often accept this better. And ultimately, the plan is to have behavioral change. That is the ultimate plan of all of this. We want our children, the next generation, to eat healthy and be able to pass on these eating habits to their children as well. So like I said before, it's often starts from the children, but it goes on to the families as well. And you want the children themselves then to have a behavioral change, to have self-monitoring, control their stimulus, because they often end up doing binge eating. And once you do all of this, then it's actually sustainable. Next, please. This is a nice, wonderful case study of ours. So she is a 12-year-old girl of Australian English ethnicity background. She was referred by her GP, and she was triaged as well about the healthy weight. So her BMI was 140% of the 95th centile, and it was complicated with liver dysfunction, mainly insulin resistance, mental health issues, which is mainly autism spectrum disorder. And so we had this child who had not only physical issues, but also obviously behavioral and mental health issues as well. So we got involved because she had comorbidities. The pediatrician was involved. The GP was obviously involved. We also got the endocrinologist on board. We referred her to Go for Fun twice. Our dietitians were involved. Weight Watchers, Light and Easy was involved. And with her ASD, we also had the support of OT and physio. And then what happened to her? So we started her on some metformin. We slowly increased it to the target dose of 2 grams per day. And we got the dietitian to help the parents, but we started her on something called a very low energy density diet, so the LED, for 10 weeks. And then once we got good weight control, weight loss, we gradually transitioned her to low energy diet, LED, and then she could have more control about her calorie intake, but it was a complete meal. So she had all the nutritional requirements in there. And the plan was to transition her to a more healthy eating routine, but to get more control of her weight with a BMI with this therapy first. And we also got our exercise physiologist involved with her. And the idea was to get her to walk, but to get her to walk faster, actually, to have a bit of endurance, to develop endurance, and also to improve her cardiometabolic health. And we got psychologists, wonderful psychologists involved, so who could motivate not only her, but also the parents, give psychoeducation to help maintain the change, and also to challenge these thoughts. What happens if you don't eat when you feel bored? What happens if you do not give in to the child when they're crying? So this is really, a psychologist is such an important part of our team. And this is her beautiful graph. So you can see that her BMI reduced by about 6.5 kilograms per meter square over 8 months. And it improved from well above the healthy weight, that is 36.4, all the way down to 29.2, which was really, really impressive. And now her height was always tracking around the 92nd to the 93rd centile, but her weight improved. She was able to walk better. Her endurance improved really well. She won her whole appearance improved, like her look out towards life improved. She became much more happy and was really invested in her weight loss, and so was the whole family. She's also doing lots of physical activities like scouts and netballs. So yeah, that's a really good graph. And we repeated the blood test, and we did see that the insulin level had come down beautifully. I don't remember from the top of my head, but it was pretty good. I think, is that it?
Sorry, I might just jump in. Faye, you might want to explain the 120, 140th percentile. How is that calculated and how we use it?
Yeah, sure. So for this case study, we had a change in BMI from what we've written as 140% P95. And so by that, we mean it's 140% of the 95th percentile for BMI. So we use the 95th percentile as our cutoff for BMI. And it's the evidence for use of any percentile greater than the 97th is really poor. So we use the 95th and then proportions of the 95th to describe anything above the 95th percentile. So 120% of the 95th percentile is the accepted cutoff for severe obesity. And then 150, 160, we tend to use in clinical practice up to 200% of the 95th percentile. So it's a nice way of describing a change in BMI for our patients as well. So if we were to look at this as a numerical percentage on our growth charts, 99% would describe every measuring point that she has above the chart there. So that'll be described as 99 point something. So it's very hard to describe the changes that she's achieved in her BMI chart. Whereas for parents, we can use a description of she is at a reduction from 140% of the 95th percentile to now 120% of the 95th percentile. And anything below that, she'll be back in our obesity range.
Okay, do we have any questions?
We do. Some of them are the same, so I'll just do the first one. So what about CRP, as this can be useful when it comes down with weight loss and better lifestyle?
Look, I have not really seen CRP in children, at least that relevant to lifestyle. I've seen them obviously with infections and inflammatory disorder, but not that, not that it explains their lifestyle, to be honest. I don't know, Faye, Slavica, Lilian?
No, and obesity being inflammatory already.
Inflammatory, but in adults, I'm not sure if we do consider in kids, do we?
No, not really. We don't really, we just do it routinely. I have seen it, but I have not seen, I've looked quite a few bloods and I've really not seen it being elevated in these children.
For kids, yeah.
Okay. And the other two questions are linked. So one is, what is the youngest age that you'll prescribe metformin? And then what is the earliest age you will contemplate intervention? So slightly different, but linked.
So I think the youngest age is about 10 years, and we would think about starting some metformin. Again, they have to meet all those criteria to start, but at some children, when they have got multiple comorbidities, after speaking with the endocrinologist, we do tend to start early. But we wouldn't do that without the expert opinion of the endocrinologist. As a pediatrician, we start from 10 years, but if they have comorbidities and we are really worried about them, then we do start early.
I think also sometimes, sorry, Faye, sometimes we take into, someone might have a little bit higher insulin that we would like, but if they have a good capacity and we know that the intervention that they under might actually assist them, that's the consideration that we don't commence them on metformin and commence them with the things like lifestyle strategies, diet, things like low energy diets or increasing really high, moderate to vigorous activities as well. We would redo the bloods and recheck. So not everyone gets with the high insulin gets metformin. So just looking at the bigger picture, I would say. Faye, any comments on that?
No, I was going to just touch on what age do we do intervention for? If you're able to flick back to our intervention types. So our service receives children from the age of 2 years of age, and we would certainly start intervention at the age of 2 because we know that obesity left untreated will not spontaneously repair or recover. So we will provide intervention to all of the children that we do see, and just the type of intervention will be then age appropriate and family appropriate, culturally appropriate. And we do really focus in on both family-based therapy, but also person-centered care. So we will start with the child or young person's goals in mind as well. So the dietary strategies here are numerous. The ones that we've listed here, this is the list of evidence-based interventions that work in this space. But what works for one child just won't work for the next. And because obesity is such a complex disease, we can't apply the same treatment to every child. So the combination of treatments, the combination of diet, exercise, and behavioural management strategies will be different for every child. So for a child who's 2, we might be looking at just fundamental movement skills because that's all around learning how to be active through play and enjoyment. And we might be thinking about something more like a traffic light diet because that's a really good educational tool for families. For somebody who is older, say 16, and has severe obesity, we might be looking at something like a very low energy diet, and we'll be using that through oral supplementation so that we have very tight restrictions around the caloric intake that they're getting, their protein intake, and making sure they're nutritionally sufficient. And that's a rapid weight loss approach, and it's appropriate for some people and not for others. For some children and young people, we'll do diet first, and once we've got some great momentum there or some engagement there, then we'll add in other layers where we're looking at other lifestyle aspects, including exercise or screen time. Sometimes we won't even touch screen time until we feel like, and the family feels like they're ready for that. But what we do know about intervention is that early weight loss is predictive of future treatment outcomes. So this is something which we didn't, as a dietitian, we used to not really believe. We would say the old adage is, if you lose it fast, you'll gain it back plus some. And that's a really strong held belief by a lot of professionals, but the evidence is quite the opposite. So we will provide intervention strategies for the families. We have a very intensive approach initially. And if we're not getting treatment effect, as we would expect it within the first month or the first 3 months, then we will revise and change our treatment strategies. Because we know if they haven't really lost any weight within that first month, they're unlikely to go on to lose weight. And so it just means we've missed the mark a little bit on our treatment intervention, and it's not quite right for that family.
Any other questions, Ben?
One just came in. When, I'm assuming it's to say when does bariatric surgery kick in?
There's no pediatric bariatric surgery available. My professional opinion is I'd love to see it as an option. I think we've worked with several young people who have BMIs of 60s, 70s, who would benefit greatly, and that would have been their chosen path. We certainly have some children and young people who come and see us hoping that that's the path that they can take. But really, even before you get access to bariatric surgery as an adult, you have to have really explored and demonstrated effectiveness with lifestyle intervention. And so even if we can, through our service, we can start children on that path, and then we will transfer them over to the adult service. And that's where, if they choose to, they can look at that as an option. Shabini, you might have more to add.
Look, I agree with Faye completely with about it needs to be an option, especially for our adolescent children who are old enough to, think about it and make an informed decision. But at the moment, it's definitely not on the cards for pediatrics. That's it.
Yeah, and I think it can sometimes be, some people have very polarizing opinions on bariatric surgery and pediatrics. But having worked with a number of these children, we've certainly seen children with BMIs in the 70s who sleep with 8 pillows because they feel like they're going to suffocate if they lie down, who are completely socially isolated. They have no school engagement, no quality of life, and really significant metabolic impacts, which are immediate. So for those children, and the ones I think of are always the ones with really complex trauma and high adverse childhood experiences. And so for those children and young people, some of the lifestyle interventions, and we can work with some of these children for 2 years or more, are not always that effective because of the complex nature of the condition.
Okay.
And just a comment that came through, it's a paradox, isn't it? Those who succeed don't need surgery. Those that fail can't get surgery.
Yes, it would seem so, yes. And it's a shame. I mean, hopefully we will have it one day as an option, but at the moment we do not.
Okay, I think we are one of the lucky districts that actually has a multidisciplinary service as well, because many other districts don't have this option either. That most of them will just have the Go for Fun or yourself, GPs, enabled to assist, and private dietitians. So we're quite lucky to have the service we have. Yeah. Okay, I think Dr. Liliane, you want to present next case study if there's no more questions?
Yes.
Okay, I'll just move down. It's okay. This was the part to just cover up for you, Shabina, learning lessons from the case study, that raising the issue with family is the first step in the weight management. This family has actually been referred to us simply by someone raising the issue with them. They didn't go to the service and ask for it. Multidisciplinary approach to weight management works even with the context of autism spectrum disorder, so it can be successful. And we know that VLED, which is very low energy deficient diet, can be prescribed successfully to young adolescents, but they need that direct dietitian supervision. And just successful weight management, like we spoke about, improves child's overall well-being psychologically as well. I mean, I've seen this girl when she commenced our service, and the last time I saw her, it is almost like a different child. Mom just presents, she talks more, she's more engaged with the family, and much happier person herself. Now I'll move to Dr. Lilian.
So be a quick one, don't worry. I think everyone's probably really tired. So it'll be just a setting and a GP like experience to share it. So was 11 years old boy. The family actually came, they're new to our practice. So they came from Sydney and living with both parents, the family, they own a restaurant here and a Chinese restaurant. No intervention since then, very healthy kids. So just as a background, knowing that gestational diabetes, it does have a big impact in the weights, on the weight of the kids, especially formula fed as well. Mommy was very engaged to talk about the kids, but it didn't actually show much concern about that. So talking about more like bit more approach, like holistic approach, asking about diet and everything. And they do have lots of big portions. And as we know, as having a bit of Asian background, they do have lots of rice as well. So big portions of carbohydrates. Lots of takeaway, drink lots of apple juice, and regular snackings like chips and chockies on a regular basis. He was doing some sports at school. Mommy was actually picking up and dropping him to be a bit quicker. He has his iPad with him, and he was sleeping a bit more, a bit less than usual because he was going very late to bed, doing like homework and actually frequently on the iPad. So lots of few bits and pieces. As I said, they came just for asthma action plan, so they didn't actually came for discussion of the weight. And when I start trying to touch the subject, actually mom said, hey, he's a big boy, and he didn't actually seem concerned. So when I plot on the chart, we did figure out that his BMI was 24.5. And it's interesting to plot on the child plot chart specifically for boys, because if you think 24.5 is actually normal for adults. So most of the parents, when I actually tell them that, they say, no, but that's 24 is not normal, like less than 25. Yeah, it's normal for adults. So I like to show the chart, and I like to actually mark and give to the parents to actually bring to the next consultation, see where we are. So how we should raise the weight and the lifestyle problems with the parents. So look, be open, non-judgmental, and to be very, very honest, surprisingly or not, they actually accept it very well. So we had a good conversation. We interpreted BMI together. We did have a chat about well above health weight, so not using obesity or severe obese. And we did discuss some few actions together. So gave to the mother the chart. She was surprisingly that actually he was not in a health weight. So it was interesting to see. We did talk about sleeping a bit more, being more active. Maybe sports sometimes is hard when the parents are very busy to bring it to footy or rugby. So we did plan maybe if we could walk for school, or maybe at least one in a way, just going to school by walk or coming back to the restaurant by walk. Drinking more water, so preferably water, leaving apple juice, or yeah, preferably never soft drinks. But anyway, if they want some juice, at least a natural juice, or looking for the less sugar containing juices on the market as well. Limiting the screen time, as you said, we tend to say an hour for younger ones and 2 hours maximum, which that's the thing, honestly, that's one of the biggest concerns nowadays, the YouTube and whatever, they really watch a lot of television, a lot of iPads. We did talk about health portions. So that's another thing as well. Sometimes parents think that eating a lot is actually good, is actually a sign that they're healthy, they're growing. But portion size were massive. So we need to also tell the parents, I know dietitian will assist me better, but I generally start talking like, have you noticed like how many times he goes for seconds or for thirds, and actually the portion of his size on the plate. So trying to give a bit more, honestly, a bit more idea what actually we can help them together to go to a better health lifestyle. I did offer the referral, I tried, but they did decline because of the lockdown now and pandemic. So they were a bit concerned about that. I said, look, happy to, we can try to organize a care plan and involve our dietitian, exercise physiologist, which I would love Faye and I would love Slavica, because we know like more towards the focus in pediatrics. But look, we tried and it did work. So we did organize a follow-up in a month. Mommy was very happy with the consultation. She mentioned, look, no one actually mentioned anything. No one actually showed me the plot on the chart. So she was very excited. So as usual, nothing is like just flowers. It was not easy. Family was engaged and kids as well, but they were still struggling with the walking to school and the pickups from school because they were busy. We did talk about implementing more fruits, like as healthier snacks, and trying the yogurt instead of ice cream in smaller portions. They did manage to drop the apple juice and leaving like small treats on the weekends, which was good. iPad was the biggest one. Kid, he was not too happy with that, but he was still engaged. He was happy talking to me. He had a good connection, but was restricted. The GP was organized, care plan was organized, but as everyone knows, as if we experience, is very busy. So we managed to have the first consultation arranged, but it didn't happen. It will happen next month. And the only thing that actually I really like as well, the perception that kids need to sleep more. So they were trying to push him to sleep a bit earlier. And mommy just say, look, I do feel that he's much more energetic. And kids just say, okay, actually feeling much better early in the morning at school. By 10, he was very tired at school, and now he's actually feeling better. And it did work. Look, it was not, as I said, don't look at just the numbers on the scales, but looking more to the family like engagement and trying to lifestyle change, which is fantastic. If you look at the numbers, oh, he lost 1.8 kilos, which honestly, I'm happy. He lost something, and families trying to go towards more health lifestyle. So I was very happy. Mommy was actually very excited. So I felt it was a very good outcome. So just showing that we can do something. I know sometimes we're very busy. Time management is a bit tricky in general practice, but look, guys, we do need to try. Prevention is essential, and we know how many problems we can have with our kids if you really don't prevent obesity in adulthood. So routine clinical management, that's something that I'm always talking to everyone. Just make sure your kids always, and it won't be something that you just pinpointing the finger that, oh, that she's overweight or have weight problems, that's why you're waiting. So trying to be non-judgmental. Everyone has your culture, your lifestyle, but we are here to help. We're not saying that's what is right. We are saying that what it should be done. So we are here to assist them, baby steps, try to minimize the overwhelming. So don't put everything together, but like lots of follow-ups, and we'll get there, hopefully. So small changes have a big impact. Always setting up realistic goals. So remember not looking at the scales, and arranging the proper referrals for the beautiful girls and multidisciplinary team as we can. And I think that's it. So key points as we had a great conversation today. I really would like to say thank you for Slavica. Honestly, Shabina and Faye was absolutely fantastic today. We did try to pinpoint a bit more about health weight in kids, and honestly, we can do stuff. We can really change lifestyle and has a significant health and social impact on their lives. So, well, we try as GPs, we should look a bit more towards to that, and knowing the pathway referrals, I think that's very handy. Important to be embedded about the BMI measurement and be aware that we need to plot on the kids chart. So that's also important to remember. Always starting a conversation, be surprised they actually feel comfortable too, and knowing the referrals. Yeah, thank you very much. I think it was very amazing today, and I'm very happy that, yeah, hope everyone enjoyed, and yeah, that's awesome. Thank you.
I would just like to point out the Pro Healthy Kids website. Pretty much any referrals you've heard from today is available. Lots of other resources as well. Also encouraging to visit the website. There is quite a few videos to watch on how to actually raise the issue and some conversation starters. So if you still feel a little bit uneasy on doing so, please feel free to visit, watch a couple of videos just for your own benefit. Also, I've put our website, our email address there. If you are willing to get any extra resources or have any questions, please feel free to email us as well. As Ben suggested at the beginning, you will be receiving a package with lots of electronic resources available for you. But we're also willing, if you provide this video address, to send you some hard copies as well.
Okay, so thank you very much for the presentation tonight. I certainly learned a bunch, even though it's not really targeted for me. It's really, really useful. I'd like to thank Faye, Dr. Kachidi, Slavica, and Dr. Shavina for attending tonight. I'd like to thank all the GPs who have attended tonight as well. You will see that the health chat evaluation link is in the chat at the moment. So if you could all please be completing that as well and sending that through. There is one final question that did come through, which was, what are the red flags that GPs need to be aware of? Things like Cushing's, Prader, Willi, leptin resistance, etc.
Yeah, so I think I would say like more extreme case, so well above health weight and signs of Cushing's. So you're seeing the strias and seeing kids having reactional hypoglycemia or high hypertension. So I would say the red flags would be like, honestly, not our general case we see every day, would be more likely to see patients with well above severity obesity. So basically well above health weight. And I would say measuring blood pressure and checking. And if you do have suspicious of any metabolic disorders, endocrinological disorders, you can start investigation and definitely refer to a proper service to deal with pediatrics.
Yeah, and stuff like genetic disorders like Prader, Willi, I guess just going through the phenotype and seeing if they fit the phenotype and their presentation, then you could do a CGH or a specific for Prader, Willi.
Mm-hmm.
So for me as a dietitian, I look for rapid weight gain as well as a really nice trigger for something's changed in their environment that's not conducive with healthy growth. But parental report is often a nice way of picking up some of the unusual or less common conditions. So some parents will often describe that hyperphagia, food-seeking behavior, stealing, hiding, finding wrappers under the bed, wrappers in their backpack. We have parents who will have a roster of where they hide the food so that the children don't know on what day the food is hidden where. So parents will often have a really nice picture that can add to your clinical picture as well.
There was a comment, I thought that was normal. I'm assuming that means for wrappers under the bed. So I've also put in the chat box there for everyone a link through to the health pathway that we have around weight management in children. This pathway was developed with the local health district as well. So some of the information that we've talked about tonight, some of the recommendations you'll also find within that pathway as well. Encourage everyone to be looking at that. Even if you're just going to health pathways for our new COVID-19 case management pathway to assist your patients who have been unfortunately diagnosed as COVID positive and how to support them during their monitoring process, you could look at that one, or you could look at weight management in children in case you want to see something that's a little bit more positive, a little bit less current times for a lot of us here as well. That was there. So I would like to thank the speakers for attending tonight. We are going to probably stay on the line for about another 2 minutes, just so everyone can access that health chat link to do the evaluation. For the speakers, if you would like to head off early, if you'd like to go and maybe have a late, healthy dinner, that's fine too. I know I'm looking forward to mine when this finishes as well. Again, for those who might have come in a little bit after I said it to begin with, if you are watching this presentation with one of your colleagues, can you please put the name of your colleague into the chat so we're aware of everyone who has attended tonight. We know who to send out the certificates for. If your name is already listed, you don't need to do that. We did get some very positive feedback as well coming through the chat as well, saying that it was a really good presentation. Thank you for your time tonight as well. So, job well done. If you guys want to head off early, that's fine too.
Thanks, Ben.
Thank you.
Thanks for having us.
Bye.
Thanks a lot.
Thank you.